Hello everybody, my name is Alyssa Peterson. I am one of the student success coordinators down on the second floor. So today we're going to be talking about hypertension in pregnancy. So we're going to talk about the difference between eclampsia, preeclampsia, chronic hypertension, the difference between mild or severe, so hypertension in pregnancy. So this is probably one of the most common medical conditions that affect pregnant women. It's going to affect about 15% of all pregnancies. So that's a huge population that pregnant mommies are coming in contact with. It's going to cause more frequent triage visits or hospitalizations for pregnant patients, which means a bigger financial burden for those pregnant patients and their families. It's also going to cause, has an increased maternal morbidity and mortality rate, which is something that's a huge problem, especially in the United States, that we're trying to combat. So this is a huge contributor to that mortality and morbidity rate. It also increases the chances of preterm births for pregnant patients, and that's going to have an impact on your neonatal mortality and morbidity rate. So it all kind of is interconnected and can cause negative effects not only for mom but for baby as well. So again, it ranges from mild elevated blood pressure in pregnancy, and then it can go all the way up to severe preeclampsia or eclampsia. And we'll talk about all the differences of those here in just a bit. So here are the different types of hypertension in pregnancy. So mom could have chronic hypertension. This means she had high blood pressure before she was pregnant. She was diagnosed either before pregnancy or is diagnosed before 20 weeks of gestation. So a lot of times, patients don't have prenatal care. They didn't have a primary care physician before they became pregnant. They never saw a doctor on a regular basis before they became pregnant. And so we don't know that they're chronic because we have no health history from them. And so if we diagnose hypertension before that 20-week mark in gestation, we're going to call them chronic. We're going to assume that they had that before pregnancy as well. But we're also going to test them and follow up with them very closely afterwards, or encourage them to follow up closely afterwards after their pregnancy to monitor their blood pressure afterwards as well. But this only happens in about 1% of pregnancies where they're considered chronic. Gestational, this is when we have diagnosed high blood pressure and it's presenting in the first time during pregnancy. So this is going to be an elevation in blood pressure, anything equal to or greater than 140/90, and we're going to find that after the 20th week of gestation. And this is going to resolve within 12 weeks of their postpartum phase. So it's kind of got a timeline for your diagnosis or an expiration date. And so this affects about 5 to 6% of all pregnancies. And then preeclampsia, this is going to be the most common types of hypertension in pregnancy. This is going to be high blood pressure with proteinuria that's diagnosed after 20 weeks of gestation. So this affects 3 to 5% of pregnancies, but is the cause of 12% of all maternal deaths. So again, going back to that mortality and morbidity rates for moms, this is a huge issue, and lots of education and preventative teaching needs to be done with these patients and trying to avoid this 12% of maternal deaths. So even further on past preeclampsia, moms that become eclamptic, it's all the same signs and symptoms criteria that is used for preeclampsia, but then they have also suffered a seizure on top of that. So they become eclamptic once they have actually seized. And then chronic with superimposed preeclampsia, these are moms that maybe were diagnosed as chronic and we're watching them very closely throughout the pregnancy, but then after 20 weeks of gestation, they then develop protein in their urine. And so they kind of get both, they kind of get double whammy. So these patients, you know, we kind of have to make sure, like, is it just something that they have that's chronic? And make sure that it doesn't get missed, that we are still checking their protein in their urine, that it's not developing into something that's a little bit more serious. So what can we do as nurses, and how do we manage a patient with chronic hypertension? So we're going to monitor them very closely. They're going to come in more frequently for their prenatal visits and office checks to make sure that their blood pressures are not getting too elevated and becoming dangerous. So your chronic hypertension is also on the rise in the US with the increase in obesity rates, so it kind of goes hand in hand. So again, teaching is a big thing with here, talking about diet and exercise with those pre-pregnancy visits and also early in pregnancy visits as well. Mild chronic hypertension probably isn't going to require any drug therapy. You're just going to watch it really closely. If they do decide to do any sort of hypertensives, it actually does not reduce the risk for developing preeclampsia, but it is going to increase. It does increase the risk of the baby developing IUGR, so you really have to outweigh the risks versus benefits of placing this mom on an antihypertensive. Women with severe chronic hypertension, anything 160 to over 110 or greater, they're recommended to definitely start pharmacological treatment. So that's when the risks outweighs the benefit for IUGR. We're going to put them on something to help control that blood pressure. So again, what am I going to do as a nurse? I'm going to teach potential complications to the patient during their prenatal visits and their pregnancy care, and then offer alternative lifestyle recommendations. So you're really going to start teaching them about diet, about recommended exercise times throughout pregnancy, what is safe exercise for pregnancy, all those sorts of things is how we're going to try to combat this issue. Gestational hypertension, these are women that develop blood pressures of 140 over 90, and it has to be at least twice on 2 separate occasions and between 4 to 6 hours apart. So you get one blood pressure reading. Sometimes that can be a fluke, right? You're not going to immediately turn around. If I take another blood pressure within the next 30 seconds and it's still elevated, that's not meeting the criteria. It has to be at least 4 to 6 hours apart. So you got to wait a little bit of time. Tell them to come back tomorrow or later in the afternoon and recheck their blood pressure again. If it's still a bit elevated, then we're going to call them gestational hypertension. Again, this is diagnosed after 20 weeks of pregnancy, and there's no proteinuria involved in gestational hypertension. So it's truly just caused by the pregnancy, but it's not severe enough where we're having kidney function or liver function involvement as well. So no proteinuria associated with gestational hypertension. And again, this is resolving after 12 weeks postpartum or within that 12-week postpartum. So when they come back and visit for their follow-up after delivery, they should be normotensive again. If they're not, then maybe they were chronic and we kind of missed it beforehand. So again, this is a temporary diagnosis. Progesterone supplements during the first trimester have been shown to reduce rates of gestational hypertension. So it's potentially something that your provider could put you on if we are suspecting gestational hypertension. So a difference, if it moves past gestational hypertension and moves on to eclampsia or preeclampsia, this is going to be more involving of and your patient's going to have signs of pulmonary edema, oliguria, seizure activity, thrombocytopenia, abnormal liver enzymes. Those are your signs and symptoms that your patient's going to display. So this kind of goes into the patho of preeclampsia and eclampsia. There's two different stages. So widespread vasospasm, endothelial injury causing platelet adherence, fibrin deposition, and fragment of the erythrocyte. Stage 2 involves response to abnormal placentas. Symptoms are going to be hypertension, proteinuria, edema due to hypoperfusion. So again, this dives down deeper into the patho. So widespread vasospasm, that's going to increase your blood pressure, decrease your blood flow to your brain, your liver, kidneys, placenta, lungs. That's why moms are going to have those spotting vision, right epigastric pain, because their liver enzymes are going to be elevated and affected. Their urine output's going to be decreased. Not going to have as much blood flow to the placenta, so our baby's going to be small, have IUGR issues, also have decreased blood flow to your lungs. So decrease in liver perfusion, that's going to equal impaired perfunction, which is going to cause subcapular hemorrhage. Signs and symptoms are going to be that right epigastric pain and elevated liver enzymes. So I have what's highlighted are your signs and symptoms, your lab values, things that you're going to see as the nurse. So decreased brain perfusion, that's going to cause small cerebral hemorrhages. That's going to cause your headache, having blurry vision, things are kind of blurry, vision disturbances. They're starting to see spots, and hyperactive deep tendon reflexes. So then your thromboxane is going to increase and your prostacyclin is going to decrease. So that's going to cause vasoconstriction in platelet irrigates, and vasodilator, and inhibits the platelet irrigates. That's going to kind of snowball your hypertensive state. Your decreased kidney perfusion reduces your glomerular filtration rate. So signs and symptoms of that are going to be decrease in urine output, increase in sodium, your BUN is going to increase, your uric acid is going to increase, and so is your creatinine, and that snowball increases the intracellular fluid and edema. So capillary refill, that's going to capillary permeability, that's going to increase in the kidneys, allowing the albumin to escape, and that's going to cause a decrease in plasma pressure to move more fluid into the intracellular space. So that's where you're going to get your pulmonary edema, generalized edema, pitting edema. So that's another signs and symptoms of moms that are preeclamptic. Vasoconstriction, again, going to cause poor placenta perfusion. Your baby's going to be IUGR. Probably not going to tolerate labor as well, and the effects of labor, just being stressed through all the contractions. They're more likely to have an abruption, fetal hypoxia, and acidosis. So these babies do not come out well, and they really struggle within those first, especially, APGARs, just getting their APGARs in their first minute to 5 minutes of life. Because they have had all these insults for such a long period of time that builds up. It's really hard for them to then cut the cord and try to breathe and thrive on their own. So here's a nice little chart that I set up for you to kind of talk about the difference between mild preeclampsia, severe preeclampsia, and then actual eclampsia. So mild preeclampsia, again, any blood pressure that's 140/90 that's detected after 24 weeks, that can be considered mild preeclampsia. Severe would have to be anything 160/110. And then eclamptic is the same. Remember, the difference between here and here is just they've had a seizure. Protein in their urine for mild preeclampsia would have to be 300 milligrams in a 24-hour urine collection, or if they're just doing a random urine sample, it would be greater than 1+ protein in a random sample. And then they will not have seizures. They typically do not show hyperreflexia. They might have some mild edema and kind of notice their face and their hands are a little bit more puffy. It's hard, especially as, say a labor and delivery nurse, because you don't know what they look like normally, right? You don't know how puffy their face is normally. And so probably they'll notice it themselves or be able to report that themselves, or their friends and family as well. So part of your intake questions as you're getting your patient settled in labor and delivery is going to be like, have you noticed any sort of swelling in your hands or face or feet? And so a lot of times they can report that to you, right? Because they look at themselves in the mirror every day, and you don't know what they typically look like. So weight gain is also going to be something that they'll notice in mild preeclampsia, which can be hard because they're pregnant, and hopefully at the end of their pregnancy they're typically gaining more weight, but someone who's monitoring their weight really closely, and maybe from 1 week to the other they've gained like 7 pounds, that's a big sign that they're having that fluid shift, and they're gaining weight too rapidly. With severe preeclampsia, instead of being 300 milligrams for 24-hour, we're going to be 500 milligrams in 24-hour, or greater than 3+ protein in a random urine sample. Again, they still do not have seizures, but they are going to show signs of hyperreflexia. So if you do your DTRs, they're going to be more like +3, +4. And they're going to show the signs of headache, decreased urine output, blurry vision, seeing spots. You'll notice pulmonary edema on your assessment. Their platelets may be dropping less than 100. They'll have headaches, right quadrant or right upper quadrant epigastric pain, and if it becomes severe enough, it develops into HELLP syndrome, which we'll talk about here in just a bit. Eclampsia, same signs and symptoms as severe preeclampsia, but then they also develop a seizure. So they'll have marked proteinuria, blood pressure is the same as severe. They'll complain of severe headaches. They also have generalized edema, but then it can go further into renal failure and HELLP syndrome as well. So if someone has a seizure, they just kind of bought their ticket into the operating room to be delivered as quickly as possible, because the cure for any sort of preeclampsia or eclampsia is delivery of the placenta. That's how we cure it. And so talk about it a little bit more, but you really have to kind of weigh the risks and benefits. If this mom is close to term and ready to deliver, and we know that the fetal lungs are mature, then it's much safer for the kid to be on the outside than it is to be on the in anymore. We need to start fixing mom and letting mom heal and get over this disease. And so the way we do that is delivery of the placenta. So this is how we're going to manage each one of these. So with mild preeclampsia, again, the cure for the delivery, or for the preeclampsia, mild, severe, or eclampsia, is delivery of the placenta. So with mild preeclampsia, we're probably going to monitor it a little bit more conservatively. We can start with bed rest at home. We're going to do continued CBC analysis, clot studies, liver enzymes, platelets, making sure that all their blood values remain normal and we don't kind of tip over into that severe preeclampsia category. We're going to do daily blood pressures while they're awake. Again, daily weights to see if they have that big shift in fluid. We're going to do daily kick counts to make sure the baby's doing okay and still moving, and we're reassured by that. And then, say we try home management and she comes into the office and her blood pressure is just kind of teetering on that severe scale, then she's kind of deemed herself like she's unable to manage it at home, and then she'll be admitted into the hospital for long-term care. So that's where you would get moms maybe admitted into the antepartum unit and monitored really closely. Your nurse is going to be doing not only kick counts, but probably fetal monitoring and biophysical profiles twice a day. They'll have daily weights. You're monitoring your blood pressure very closely in the hospital, monitoring for any signs and symptoms, headache, blurry vision, right upper quadrant pain. And this can be kind of a bummer, right? Because then, depending on where they are in their pregnancy, and they end up getting admitted into the hospital, they could end up being there for weeks or months at a time, just kind of buying their time and getting closer to term, or as close to term as possible it is to keep mom safe and baby still growing. So we're probably going to give lots of enrichment things for mom to do while they're kind of stuck in the hospital for the time being. If it moves over to severe preeclampsia, this is where it's going to require hospitalization. They're going to be on complete bed rest, and typically try to keep them in the left lateral position. We want to put them in a quiet environment, so they're not necessarily going to be in the middle of the unit closest to the nurse's station like you would, put someone who's at a fall risk or something like that. You want them in a quiet environment. You don't want them in the middle of the unit. So you kind of want them at the end of the hallway where you can dim the lights and keep it quiet for them. You're gonna initiate seizure precautions by patting their side rails, making sure that your oxygen and suction are available. And then you're gonna probably start them on an antihypertensive as well. So there's a list of antihypertensives that we typically use for moms with severe preeclampsia. It's on page 677 on table 19.3. So we want to assess and make sure that their vision and their level of consciousness is intact. We're going to do strict eyes and nose every hour. We're going to assess for acute pulmonary edema, close monitoring of the fetus. We're doing non-stress tests or growth ultrasounds, probably weekly. And then if we're getting closer to delivery and we're trying to decide when's the best time for delivery, we can do an amniocentesis to determine fetal lung maturity. And so if baby's lungs are mature enough and it's safe for us to deliver, then we're going to go ahead and deliver probably a couple weeks early. We're going to do Doppler screens to make sure that the placenta and the cord are still working well for us and circulating blood to the baby, and biophysical profiles. We're also monitoring mom's labs very closely, probably daily. We're going to do liver enzymes, ALT, AST, creatinine, BUN, uric acid, glucose, CBC, platelets, coag studies, PT, PTT, 24-hour urines. And so if we're all started creeping and deciding that it's probably safer for mom to deliver, then we'll probably initiate magnesium sulfate. And so we'll talk about mag here in just a little bit as well. So again, if they're eclamptic, now that they've kind of shown and proven that they're so severe that they've actually seized, safety is your number one priority, especially during a seizure. So what you'll do as the nurse, you're going to turn them to their side, stay with the patient, and call for help. That's a big NCLEX style question that a lot of exams will ask, or potentially your NCLEX as well, because it's a big safety concern. You don't want to walk in, realize your patient's seizing, and then run out to go get help. You need to stay with the patient, document everything very closely. You're going to kind of write it as an emergency event, and document the times and what happened, when it happened, who came, who was called, when did they actually get to the bedside. And so after a seizure, make sure that you're suctioning and applying oxygen. If MAG wasn't already started, we're definitely going to continue it. And again, we're going to deliver as soon as possible. As soon as she's stable, as soon as she stops seizing, we're unlocking the bed and run into the OR to get that kid out as quickly as possible. So magnesium sulfate. So the purpose of MAG is to decrease the likelihood of the patient to have a seizure. So a lot of people have a misconception with, well, she's on it because she's got high blood pressures, so this medicine is going to help lower their blood pressure. It's not that. It's to help decrease the chances of them having a seizure. So when they're on magnesium sulfate, you're going to be doing neuro assessments. So preeclamptic patients are going to be hyperreflexia. They're going to be that +2, +3 on your deep tendon reflexes. And so I always kind of associate and kind of compare magnesium. It's kind of like you're walking a tightrope. You want it at a high enough level in their body where it's therapeutic to them. It's doing some good. It's helping prevent them from having a seizure, but you don't want it too high to where then they become magnesium toxic, and then they have diminished or decreased deep tendon reflexes. They have difficulty with their level of consciousness. They have difficulty breathing. And so you have to monitor that very closely when you have these moms that are on MAG. So therapeutic magnesium level range is anywhere between 4 and 7 milliequivalents per liter. So typically moms that are on MAG, we're at least doing, it depends on your facility, but a lot of times moms that are on magnesium sulfate for hypertension or preeclampsia, they're monitoring their MAG levels, serum MAG levels very closely, at least every 4 hours, to make sure that those MAG levels aren't kind of creeping up. But we're still assessing for signs and symptoms of that as well. So you're doing a neuro check every other hour, every hour, and you're watching your eyes and nose really closely as well. So moms, basically, if you're severe enough to be started on magnesium sulfate, then you're severe enough to deliver, right? If it's severe enough that we think that you're at risk for a seizure, then we need to get that kid out as fast as possible. So that might be involving administering steroids to the mom to make sure that the fetal lungs are mature. Some providers will still allow them to labor and attempt to deliver vaginally. We just have to, again, monitor their blood pressures really closely, because then you add the stress of labor on top of someone who's already hypertensive. That could kind of 1 + 1 = bad. And then if they are really truly too severe, we think it's safest to get the baby out as quickly as possible. They'll just go straight back for a C-section. They won't even allow the patient to attempt to labor. After a delivery, whether it's a vaginal or a C-section, we're still going to continue that magnesium for 24 hours postpartum. So those moms typically are going to stay on the labor and delivery unit for another 24 hours after they deliver, so that they can be monitored closely and in a more acute setting, because they're still at risk for seizures. So moms that are on MAG, there are also special protocols because they feel a little sleepy and tired with the magnesium. They can't be left alone in the room with the baby or the infant. So a family member or partner has to be with them. There shouldn't be any bed sharing anyways, but especially no bed sharing with a mom that's on magnesium, because they're so sleepy and tired, they could very easily kind of roll over and injure the baby with the baby in the bed. So we make sure that if they don't have any friends or family members that can stay with them, that either a nurse is then there with them, or that the baby gets transferred to the nursery while there's no visitors present in the room. So that's another reason we keep them on the labor and delivery unit side. So it's just closer observation. So anyone that's on MAG automatically gets a Foley because we're wanting to make sure that their urine output is adequate. And so once after delivery, mom maybe starts diuresing a little bit more, and you'll notice it, like you're checking her urimeter and it's 50, 40, 60, whatever every hour, and then all of a sudden you go to check it 1 hour and it's like overfilling, it's 250 for that hour. And so that's a kind of a good sign that your mom's turning the corner. They're starting to excrete that protein out of her urine, and that her kidney and liver function is starting to return to normal after the placenta's been delivered. So again, signs and symptoms that you want to look for from MAG toxicity: deep respiratory depression. They're having a hard time breathing. You're assessing their deep tendon reflexes, and they have absent or very diminished deep tendon reflexes. Their urine output is going to be less than 30 mils in an hour. MAG levels are greater than 8. Then we're being concerned about MAG toxicity. The antidote for MAG toxicity is calcium gluconate. That's a really prevalent question that you'll probably see on an exam or in NCLEX itself. So know that if your mom is showing signs of MAG toxicity, turn the MAG off, grab the calcium gluconate, and administer that for the antidote. So HELLP syndrome is a very specific diagnosis that is only related to lab values. So it means hemolysis, elevated liver enzymes, and low platelets. So your red blood cells become fragmented as they pass through small damaged blood vessels. You have elevated liver enzymes are the results of your reduce in blood flow. Low platelets are caused from vascular damage. And so you're going to have an increased risk for cerebral hemorrhage, retinal detachment, hematoma of the liver or rupture of the liver, acute renal failure. That kind of maybe can potentially cause DIC. Your placenta abruption risks increase, your sepsis risks increase, and then you can actually end up having a mom that strokes as well. So the management of this is you're going to want to give something that's going to rapidly reduce your blood pressure, especially if we have those moms with severe high blood pressures. I think the highest I've ever seen for mom that was preeclamptic, 270 over 140. I mean, they were crazy high. Let's see. We're going to prevent seizures, so start her on MAG immediately. You're going to start with a loading dose and then give her a maintenance dose for the duration of her labor, and then within continue at 24 hours after that as well. Delivery as quickly as possible. And so sometimes, depending on where this hits in their pregnancy, say they're 34 weeks, we might have to wait 24 hours to get those steroids on board. So we'll start them on magnesium, give them something that's going to rapidly lower their blood pressure, give the steroids as quickly as possible, and then just monitor it very, very, very closely for 24 hours, trying to give the baby that benefit of the steroids to get them on board so that their lungs can be as mature as possible, or give them as much surfactant as possible for them to have a better outcome after delivery. And then if their blood work becomes really severe, maybe their platelets are super low, then we can also give blood component therapy as well. So fresh frozen plasma, packed red blood cells, or platelets are all things that we can give mom if their lab values are trending in a dangerous direction. So Nursing care for moms on magnesium. Again, we're going to do neuro assessments every hour, every other hour, depending on your facility. That includes your level of consciousness, deep tendon reflexes. We're going to assess for clonus, because if they show signs of clonus, then that means that their central nervous system is affected, and that might be kind of like a precursor to moms that are potentially going to end up with eclampsia and have a seizure. We're going to listen to their lung sounds and watch their respiration rates, making sure that they aren't don't have depressed lung sounds or a slowed respiration rate. Watching their eyes and nose really closely. Like I said, any mom that has magnesium, they also bought themselves a Foley with a urimeter, so we're assessing urine output every hour. Obviously, these aren't moms that are going to get up and be able to walk around the halls and able to labor naturally. I mean, they could still go without an epidural, but they would need to have continuous fetal monitoring and strict bed rest throughout their labor, which makes it a little bit more difficult to labor naturally without an epidural, because then you can't get up and move around as freely, and it hurts a lot more to just sit in bed and wait for your next contraction. So education is a big nursing component to moms that are on MAG, keeping moms updated on what's happening, why we're doing this, what's the reason for this. It can be really overwhelming for moms to get this diagnosis of eclampsia or preeclampsia, and so just really informing them and updating them and supporting not only them but their family as well, and again having them in a quiet spot and maintaining your seizure precautions. So we're going to do some practice questions. A nurse is caring for a patient who has been diagnosed with severe preeclampsia. The patient is on magnesium sulfate IV, 2 grams an hour for severe seizure prophylaxis. Which of the following findings would indicate the magnesium sulfate toxicity? Select all that apply. So what are our toxicity signs and symptoms? Respiration rate less than 12 a minute. Urine output is less than 30 mils an hour. Hyperreflexic deep tension reflexes, decrease in level of consciousness, or flushed and sweating. So what are our signs and symptoms of MAG toxicity? It is going to be respirations less than 12, urine output less than 30, and then a decreased level of consciousness. Remember, hyperreflexic deep tendon reflexes, that's a sign that there's central nervous system involvement, and that's what we're going to expect with someone that has preeclampsia. If they're diminished, then we would be considered MAG toxicity. And then actually anyone that's on MAG, they already feel very flushed and sweaty. A lot of women describe it as they feel like they're burning from the inside out. They get very hot. It's almost like flu-like symptoms. They get hot, sweaty, clammy. They just feel very sleepy and drowsy. But if it becomes, where I can't wake them up and they're not responding to me as I walk in the room, then we're probably inching more towards MAG toxicity and not necessarily just the normal effects of magnesium sulfate. Nurse is caring for a client who's receiving IV maintenance dose of magnesium sulfate. Which of the following medication should the nurse anticipate administering if the patient starts to show signs and symptoms of a magnesium sulfate toxicity? So again, what's our antidote? Nifedipine, pyroxidine, ferrous sulfate, or calcium gluconate? Calcium gluconate is your antidote. Remember that one. A nurse is caring for an adolescent client who is a gravida 1, para 0. The client was admitted to the hospital at 38 weeks of gestation with a diagnosis of preeclampsia. Which of the following findings should the nurse identify as inconsistent with preeclampsia? So which one of these is not related to preeclampsia. +2 pitting edema on the lower extremities, +3 in the urine, +3 protein in the urine, blood pressures of 148/98, or deep tendon reflexes of +1. So again, which of the findings of the nurse identify as inconsistent or not related to preeclampsia? And that's going to be your deep tendon reflexes of +1. So remember, they're going to be hyperreflexive with preeclampsia. Once we start them on MAG, if we're concerned about MAG toxicity, they'll be hyporeflexive. Everything else we're going to see with our preeclampsia. These are all our signs and symptoms or criteria to be diagnosed with preeclampsia. High-risk pregnant client is determined to have gestational hypertension. The nurse suspects that the client has developed severe, missed an E there, severe preeclampsia based on which finding? Mild facial edema, protein in their urine 300 milligrams for 24 hours, blood pressure of 150/100, or blurry vision. So what is our sign and symptom of severe preeclampsia? So they have, mild facial edema. That is associated with mild preeclampsia. Proteinuria 300 plus is mild preeclampsia, 500 plus is with severe. Blood pressures of so we can kind of eliminate these two. Blood pressures of 150/100 or blurred vision. So it's actually going to be blurred vision. So in order to be considered severe, it actually has to be 160/110. So even though this is a crazy high blood pressure and this is something that we should definitely be concerned of, it doesn't meet our criteria in order to be considered severe. But remember, severe is when they're going to start having those signs and symptoms: headache, oliguria, blurred vision, all those things that we talked about before. So this is actually what we're considered to have severe preeclampsia. A nurse is admitting a client who has severe preeclampsia and is at 35 weeks of gestation, and she's reviewing the provider's orders. Which of the following orders requires clarification? So assess deep tendon reflexes every hour, ambulate twice a day, obtain daily weights, or continuous fetal monitoring. So remember, kind of talked about this a bit. If we're severe preeclampsia, then we're probably either getting steroids on board to deliver, starting her magnesium, scheduling a time where she can go to the operating room. So we're going to monitor that very closely. So we should question that they are allowed to get up and walk around twice a day. They're in the hospital, they're admitted for close observation, they're strict bed rest, they're not going to be able to get down and roam the hallways. Sometimes, and this is not, you probably won't be texted over this, but just kind of real world application, they'll kind of let them do a 30-minute wheelchair ride once a day, just so that they can get out of their room, try not to go quite as stir crazy, but they have to remain in the wheelchair and remain with another adult, whether it's a family member or a nurse, that they can just go outside for just a minute and get some fresh air, so they're not completely go crazy just staring at the four walls in their room for who knows how long. A nurse recognizes that documenting accurate blood pressure is vital to a diagnosis of preeclampsia and eclampsia. The nurse suspects preeclampsia based on which finding? So blood pressures of 140/90 on 3 occasions after 20 weeks of gestation, blood pressure of 140s/90s on 3 occasions occurring 3 hours apart, blood pressures of 140/90 on 2 occasions occurring 6 hours apart, or blood pressure's 140 over 90 on 2 occasions after 28 weeks of gestation. So we can kind of eliminate this one because we know it has to be after 20 weeks. So we've missed an 8-week window there. We can eliminate, we can eliminate here because that's too close, that 3 hours apart. So it's between A and C. So is it 2 occasions, 6 hours apart, or 3 occasions, any 3 occasions after 20 weeks of gestational age? So it's actually C, 2 occasions, 6 hours apart. Still has to be after 20 weeks, but because it says 3, that will eliminate that answer choice. Okay, so here's our next question. A pregnant woman is being evaluated for HELLP. The nurse evaluates the client's diagnostic results. Which result would the nurse interpret as helping to confirm this diagnosis? So is it going to be elevated LDH, elevated platelet counts, elevated white blood cells, or elevated hematocrit? So remember, HELLP stands for hemolysis, elevated liver, and low platelets. So we can eliminate B because that's elevated platelets, and we can eliminate D because that's elevated hematocrit. We would have decreased hematocrit if we're having hemolysis. Nowhere in there does it state anything about white blood cells, so our correct answer is going to be A, elevated LDH. That's going to be your liver enzymes. Okay, let's move on. A woman is being closely monitored and treated for severe preeclampsia with magnesium sulfate. Which finding would alert the nurse to the development of magnesium toxicity in the client? So is that going to be diminished reflexes, seizures, elevated liver enzymes, or a serum mag level of 6.5? So a seizure would mean that we've then become eclamptic, and probably our magnesium isn't working well for this patient because obviously it's not at a high enough level to be therapeutic for them. They've transitioned into eclampsia. Elevated liver enzymes doesn't have any effect of the severity of or the effectiveness of the magnesium, or if they're toxic. So we can eliminate C and B. So now we're down in A and D. So diminished reflexes or magnesium sulfate level of 6.5. So if you remember, our therapeutic level for magnesium is anywhere between 4 to 7. So we're right in the middle of our therapeutic range with a mag level of 6.5. So we're not concerned about mag toxicity if that's our serum level. So the correct answer would be A, diminished reflexes. So if you go in and do your neuroassessment for that hour and your reflexes have been +2 the entire time, and now all of a sudden you can't get your reflexes, or you're having a really hard time waking up your patient, or them keeping their eyes open and able to maintain their level of consciousness, that's when we're concerned about mag toxicity. Client has come to the office for a prenatal visit during her 22nd week of gestation. On examination, it is noted that her blood pressure has increased to 138 over 90. Her urine is negative for proteinuria, and the nurse recognizes which factor as the potential cause. So we're 22 weeks. We do not have protein in the urea, and our blood pressure is 138 over 90. So is this gestational hypertension, preeclampsia, HELLP syndrome, or chronic? So chronic would have to be diagnosed before 22 weeks, or before 20. HELLP syndrome, I know, is has to do with her lab values, and I don't have any lab values in the stem of my questions, so I can eliminate that. And so, is it between gestational hypertension or preeclampsia? So, remember, preeclampsia, they do have protein in the urine. With mild, it's 300 plus. With severe, it's 500 plus. So I can say that this is not just, but it is gestational hypertension. So hypertension without proteinuria after 20 weeks. It's going to resolve after 12 weeks of postpartum. Their blood pressure is anywhere elevated of 140s over 90s. Doesn't say that we checked it twice on 2 occasions, 6 hours apart, but all the other signs are kind of there, and so that is our best answer choice, is gestational hypertension. A pregnant woman has been admitted to the hospital due to severe preeclampsia, which will be important for the nurse to include in the plan of care. So plan for immediate induction of labor, admit the client to the ICU where she can be constantly monitored, initiate and maintain seizure precautions, or initiate NPO status. So this is a really great question because it really evaluates what is your job as the nurse for someone who has this diagnosis. So we can eliminate moving them to ICU. I guarantee you an ICU nurse is not going to know what to do with someone who is pregnant with severe eclampsia. We want to keep them in her area, in her specialty area, and so we're not going to move her to the ICU bed. We plan for immediate induction of delivery, induction of labor. So it's probably definitely something that we're going to be anticipating, but that's not actually our call as the nurse. I can't write the orders for her to start her induction. So even though that's probably something that will happen, that's not our call as the nurse, or our responsibility as the nurse. So we're down to initiate and maintain seizure precautions or initiate NPO status. So it's actually going to be initiate and maintain seizure precautions. Anyone that is admitted into the labor and delivery unit for either induction or just active labor, they're either NPO or clear liquids anyways. And so the key words here being severe preeclampsia, this is what I'm going to initiate as the labor and delivery nurse. I know she's at risk for seizures. I know she's at risk for developing into eclampsia. I'm going to pad the side rails. I'm going to make sure my oxygen's ready. I'm going to make sure my suction's available, and have everything anticipated for and available if she does actually seize. Okay, and that's all I got. Hopefully this was helpful for you. If you would like to come down to Student Success and discuss this further, if you have any sort of questions, please feel free to email me, or you can book an appointment through the link as well. Or you can give me a call. So again, I hope this was helpful for you, and have a good night.